Egyptian patient, the Egyptian patient will tell you something. The Iraqi patient will tell you something else. So we need to identify each term, what the patient will tell you about each term of this one, because each one of these terms means something in field of vestibular medicine. So taking history is to differentiate between these terms. Dizziness is sensation of disorientation or increased personal efforts to be oriented. يعني البيشنت راح يجي يقول لك احس نفسي مسطور، احس نعاس شديد، شلون كانه اخذ داخل راسي بالفراش، هذا شنو؟ هذا dizziness. Causes of dizziness, any cause that lead to vertigo may lead to dizziness. Chronic vertigo can lead to dizziness, like vestibular hypofunction, bilateral vestibular hypofunction, unilateral vestibular hypofunction, labyrinthitis, vestibular schwannoma, vascular causes, atherosclerosis, anemia, dehydration, arrhythmia, orthostatic hypotension, stroke, transient ischemic attack, neurological causes like multiple sclerosis, degenerative causes on Parkinson's disease, stroke, brain tumor, medications, very important, alcoholism, stress and anxiety, hypoglycemia, and cervicogenic dizziness. So it is important to differentiate whether the patient has vertigo or only dizziness. If the patient has only dizziness, we should go for search about systemic causes of that dizziness, not keep our mind only on the vestibular system. We need to think about all of what I mentioned, the causes. Positional dizziness, that dizziness induced by sudden change of head position, such as lying down or looking upward, usually associated with benign positional vertigo and with unilateral vestibular hypofunction. Nausea تعرفوها، يقول لك مريض يعني عفوا عندي تعبان نفس, sensation of unease in the stomach associated with involuntary urge to vomit. Motion sickness or trouble sickness occur in patients that are oversensitive to movement, characterized by nausea, vomiting, pillar, and sweating when traveling on a moving vehicle, whether it is car, whether it is a boat. المريض يجي يقول لك جماعتنا العراقيين ادوخ بالسياره، او يقول لك او مثلا سياره تمشي سريع انا بعد ادوخ ما اتحمل ورا 80 ورا 100 كيلومتر بالساعه، او يقول لك مثلا انا بالسياره طبيعي بداخل المدينه بس من اطلع مسافات بعيده على الخطوط السريعه يصير عندي دوخ، هذا كله موشن سنسيتيفيتي، موشن سيكنس. او جماعتنا يقول لك انا شايف الكيات، يقول لك انا بالكي من اقعد بالعكس بالكرسي بالعكس ادوخ ما اتحمل، هذا كله موشن سيكنس. Troubled sickness. Lightheadedness is feeling of likelihood to get fainting, reported in patient with uncompensated peripheral vestibular disorder, transient ischemic attack, basilar migraine, acute anxiety or panic attack. المريض يجي يقول لك احس نفسي ما مسيطر، ما متوازن، او احس اريد اوقع، كل هذه lightheadedness. Moodiness, sensation of unclear head, commonly reported in patient with uncompensated vestibular hypofunction. يقول لك احس ثقل براسي، احس راسي ثقيل، هذه كلها moodiness. شنو التريتمنت؟ طلاب البورد. شنو التريتمنت of uncompensated peripheral vestibular disorder? Any suggestion? Physiotherapy is the only treatment. Physiotherapy. Don't go for labyrinthine sedatives. This patient needs only physiotherapy. Now, imbalance, it's difficult to maintain center of the gravity. المريض يقول لك احس نفسي اترنح من اوقف، من امشي احس احتاج امسك فد شيء، هذا كله imbalance. Reported in uncompensated peripheral vestibular disorder and bilateral vestibulopathy. What is treatment? Again, is physiotherapy. Movement disequilibrium, transient imbalance on sudden movement, usually associated with unilateral vestibular hypofunction, which is uncompensated treatments, just the same physiotherapy. Mild debarkment syndrome, feeling, هذا could be physiological, اللي هو feeling of slight rocking sensation for several hours after debarkment of a boat trip. يعني واحد راكب باخرة يومين، وصلت الباخرة يحس الأمور ما متزنة، فد ساعة نص ساعة، هذا physiological. When this symptoms continues for more than few weeks, it is called Markman syndrome. راح يصير هذا disease. Drop attack, abrupt episode of fall that can occur without any warning. It's usually associated with late stage of Meniere's disease. شو نسميها؟ Demarcine crisis. Good. This is Demarcine crisis. Yes. Now vertigo. We have classical vertigo, which is illustration that it is illusion that the patient body or surroundings environment is spinning or tumbling. Tumbling شنو بالعربي معناها حركات پهلوانية. Tumbling. There are two classifications: internal vertigo, patient body spinning or tumbling, and external vertigo, which is oscillopsia, surrounding the surroundings of the patient is spinning. So, oscillopsia is one type of vertigo. Keep that in your mind also. Visual vertigo, feeling of loss of control and discomfort by rapidly changing visual stimuli due to overwhelmed balance system. يعني شلون يقول لك المريض أنا زين صرت زين. كان عندي فيرتيجو صرت زين، بس بالمول من اشوف المصعد يصعد وينزل، من اشوف الدرج الكهربائي احس نفسي خلاص احس المول كله قام يفتر لي. هذا شنو؟ هذا visual vertigo. Also you should keep terms in your mind. This is usually associated with uncompensated vestibular hypofunction, and treatment is شنو؟ اسمع من عندكم. physiotherapy. Usually associated with chronic حكيناها والتريتمنت حكيناها. Other classification of vertigo. Rotatory vertigo is illustration of spinning, rotation. Is usually a sign of acute vestibular. This is acute vestibular. يقول لك spinning. الدنيا تفتح. Non-rotatory vertigo is usually illustration of other movement like forward, backward, or vertigo. Chronic, non-compensated vestibular or central vertigo can present like that. Causes of vertigo, a lot of causes, I don't want to go through them, but the good news for you, that if you know the 6 most common, benign positional vertigo, vestibular migraine, Meniere's disease, acute vestibular neuritis, chronic vestibular hypofunction, and acute labyrinthine failure, which is around 8%. This is the most common, represent 8% of causes of vertigo. Can only be diagnosed by history, by your good history and your good physical examination. So it is an art. If you have good art of your good history of physical examination, you will reach the diagnosis of more than 80% of the most common causes of vertigo. Now, duration حكاها دكتور فراس, seconds benign positional vertigo, vestibular paroxysmia, minutes Meniere's disease, hour vestibular neuritis, labyrinthitis, more than a day vestibular migraine. هذه أيضا السيناريوز حكاها دكتور فراس خلينا نضيع وقت فيها. Examination. Now we reached it. When we examine patient with vertigo or with dizziness, we should keep in our mind that we are examining 3 systems: the vestibular, the visual, the proprioceptive, and the central, the cerebellum, which is the interpretation of all these data. Why we need to examine the eye first? Because we should exclude specific eye pathologies like diplopia, like ophthalmoplegia. If we don't exclude them and go for physical examination, it is a real problem for that patient. So, vestibular ocular reflex, now we have our roles. Keep these roles in your mind. If you keep these roles in your mind, you will be good in your examination. Role 1, vision input is superior to vestibular input. If you need to examine the eye of the patient, which is due to vestibular problem, nystagmus due to vestibular problem, it should be done with vision denied. يعني انت مريضك عينه مفتوحه وتيجي تفحصه for spontaneous nystagmus, you will not get it because opened eye lights of your room will suppress the vestibular nystagmus. So you'll get nothing from your patient. Simply you'll get nothing. You will miss your spontaneous nystagmus of your patient. So you need to cover the eye and keep looking to the eye simply by use a Frenzel, or very cheap by use goggle. This is equal to $3. This one is equal to $3. It is developed by Professor Michael Strutt, and it is very cheap and it's very effective. So examining eye for peripheral nystagmus, for vestibular nystagmus, is just like examining a tympanic membrane without otoscope. Imagine yourself as otolaryngologist and you are examining the tympanic membrane without the otoscope, you'll get nothing. It's just the same. Now, use of amgaggle or Frenzel leads to suppression of vision. يعني patient بعد راح ما يشوف شيء من surroundings, but keep examiner looking to the eye so we can get the peripheral nystagmus, the vestibular nystagmus. And please see this video. This is a demonstration of nystagmus. You can see there is slow phase and rapid phase. There is slow phase and rapid phase. And slow phase is usually labyrinthine, while the rapid is central compensating. Keep in your mind, this is very important. Direction of nystagmus depends on the rapid phase. يعني هسه هنا هذا النystagmus وين left or right? This is left nystagmus because the rapid phase directed to the left side. Yes, wonderful. Spontaneous rule 2. Slow phase is directed towards the diseased labyrinth. Rapid phase is directed toward the normal labyrinth. This is rule 2. Keep in your mind, please. So in our scenario, we have diseased right labyrinth, and the nystagmus goes spontaneously to the left. The rapid phase will be to the left. Now, rule 3, Alexander's law. This is very important. Phenomena in which the spontaneous nystagmus of a patient with vestibular lesion is more intense when the patient looks to the direction of the quick phase. So, in our scenario, when the patient looks to the right, there will be more nystagmus. Please see this video. This patient with acute vestibular neuritis and have clear left-sided nystagmus, and when looks to the left, it's just become more intense, more clear. When looks to the right, you can see it's just suppressed, no nystagmus. So this nystagmus follows Alexander's law. So this is peripheral vestibular nystagmus, because any nystagmus against this law is central nystagmus. We should think about central pathology. Changing direction nystagmus is also a sign of central pathology. Pure vertical, pure torsional, also a sign of central pathology. Looks to this patient. What is the direction of nystagmus? Asma. It is vertical, downbeating nystagmus. Yes, this is a downbeating nystagmus. You can see downbeating nystagmus, vertical nystagmus is more intense on lateral gaze. Please see what will happen when patient looks to the left. It will be more intense. Can you see? It is more intense, more clear, downbeating nystagmus, and this patient have diagnosed to have ischemia. It was stroke in the cerebellum. Head impulse test, it is a reflex helpful to maintain corrective eye position during the change of head position to correct eye movement rapidly so the vision remains to the target, also known as head thrust test. You can do it clinically. If you have a video head impulse test, that's great. But if you don't have it, you can do it clinically. You can get information clinically. هنا يعني ما السكات تبين خلينا بدك نلحق شوي الوقت احنا يزاحمنا شوف هاي السكات هذه السكات when turning to the right there is سكات, so this is right vestibular hypofunction. Skew deviation, vertical alignment of two eyes, usually a central sign. خلينا نوقف الفيديو. العين تنزل لي جوا لما نغطيها، العين تنزل لي جوا شوي الوقت يزاحمنا. Hint sign. Patient اجاك acute vertigo. Is this vertigo is central or peripheral? If there is spontaneous nystagmus which follows Alexander's law, there is seconds on head impulse test, no skew deviation, this is vestibular neuritis, this is peripheral. If there is central nystagmus which is against Alexander's law, and there is normal head impulse test, clinical, you can do it clinically, you don't need to go for further. And there is skew deviation, very simple, clinical test. This is central, and this is, imagine, this is more sensitive than MRI in detecting stroke in the first 84 hours. So it is an art of your history and physical examination. Imagine your clinical test is even more sensitive than MRI testing in the first 84 hours by doing simple hand sign. Nystagmus induced by head shaking for a patient which is with vestibular neuritis, which is not fully compensated. If you don't get the spontaneous nystagmus, you can just shake the head and you can see the nystagmus. I have no time to show this video. If anyone wants to see the video, you can do it after the session because I don't want to exceed the time. After Berger test on stepping, there will be deviation to the disease size. This is rule 5 in the Ewers law. Ewers law, very important. Stimulation of the semicircular canal causes movement of the eye in the plane of the stimulated canal. يعني هسه simply انت تيجي البيشنت يسوي له ديكسول بايب لوين للرايت سايد. هنا صار عندنا شنو؟ صار عندنا ستيميليشن للرايت posterior canal and stimulate contralateral stimulation of the left anterior canal. والمحصله زيرو. هسه البيشنت ما عنده nystagmus. Keep in your mind that autoconia when moves in the canal, this is stimulatory. إذا عندنا autoconia بالرايت posterior والبيشنت سوينا ديكسول بايب صار عندنا overstimulation due to autoconia, there will be the vertical torsion of the nystagmus. So this is goes with Ewers law. Ewers law, it's very important to diagnose. So according to Ewers law, when stimulate the right posterior canal, there will be anti-clockwise upbeating. Left posterior canal, clockwise upbeating. Right horizontal canal, right side nystagmus. Left horizontal canal, left side nystagmus. This is very important. This is very important for you. Right anterior canal, you will get down beating, anti-clockwise torsional. Left anterior canal, you will get down beating, clockwise torsional nystagmus. If you remember this slide and you do positioning, you will not lose your patient. You will not lose the diagnosis. You will get your art of clinical examination. So Dix-Hallpike test, the good news is that Dix-Hallpike test is not a test for one canal. It is a test for all canals. It is a test for all the semicircular canals. So when you're doing right Dix-Hallpike test, you are stimulating the right horizontal, the right posterior, and the left anterior canal. So it is not enough that the patient gets dizziness to say that this is benign position vertigo. No, this is wrong. And it is not enough even to get nystagmus to say that this is posterior canal, because probably if you get horizontal nystagmus, no, this is lateral canal. So you should know the direction of nystagmus that you get by this procedure. Then you can diagnose the canal involved by benign positional vertigo. Other positioning tests, Simon test, supine roll, supine head hanging, bow and clean test, minimal strategy. We don't, of course, it's very important, but we again don't have time to go through. Other form of induced nystagmus, nystagmus induced by chair rotation, induced by hyperventilation, by vibration, by loud sound, by valsalva, or by looking to a fixed object, which is called gaze evoked nystagmus. Again, this is very important, a central sign of central pathology. Test of Saccas, very important. You don't need to go for BNG. If you have BNG, that's great. If you don't have, you can do it clinically. Just keep your patient in front of you and ask your patient to look to your fingers. And you can see the movement of the eye of the patient. If it's go normally, this is normal saccadic eye movement. If there is some problem, that this is a central sign. It means that the cerebellum doesn't correlate in the correct way. Smooth pursuit. Also, if you have a VNG, that's great. If you don't have it, you can't do it clinically. Again, you can't do it clinically. You just ask the patient to look to your finger and just ask the patient to follow the finger. And you can see if the movement is smooth, that's great. If there is abnormality of the movement, this is central sign. If there is saccadic movement, يعني العين تتحرك بس تتحرك saccadic. ما تتحرك smoothly. This is also a central sign of that there is some problem in the cerebellum. Optokinetic response is just the same. Test of proprioception. How we can test for proprioception? How we can test for that? How we can test أي واحد يلا. How we can test for proprioception? How we can test for proprioception? Proprioception. How we can test for proprioception? بعد. How we can test for proprioception? How we can test for proprioception? Very simple. Very simple. You test proprioception by doing a tonic fork test. تحتاج 256 tonic fork. تخليها عني joint تحس اكو proprioception لو ماكو. هذه very simple. By use of your tonic fork بس تحتاج ال 256 ما راح تحتاج ال 512 اللي تستخدمها بالاوديولوجي. And for cervicogenic dizziness, you need to perform this test. A laser head. شلون عندنا الهيد لايت مال انتي بس ليزر وتخليه على نقطه وتقول للمريض غمض يحرك راسه المفروض يرجعه قريب من السنتر اذا اقل من 7 centimeters it means that this is normal. If there is loss of distance that means there is some problem with the cervicogenic proprioception. It means cervicogenic dizziness. A Romberg test. Again, it is not a test for proprioception only. It is a test of everything that you are testing. The vestibules, that you are testing and look at this video, please. This is from one of the best professors in the field of vestibular medicine. These patients, like he stands and close the eyes normally, and he can stand normally without any problem. It is very important to do this test. What's called Romberg blast by with or without foam. You need to have a foam. بسيط جيب لك مجرد جيب لك دوشه مال طفل خليه بالعياده مالتك. شوف هسه شو راح يصير بيه هذا البيشنت. وقف على الدوشك على الفوم. اذا عندك فوم مال هاي الرياضيين تشتري بالقاعه الرياضيه تثبته. واذا ما عندك دوشك مال ابنك الصغير تستخدمه بالعياده. It is good for you. And when close the eye, looks what will happen. Immediately he falls. What it means? Diagnosis. Spot diagnosis هذا. هو واقف هالشكل ومغمض الفستيبولار سيستم يشتغل مضبوط بدا يوقع. خلينا له فوم سوينا سبتراكشن المن للبروبريوسبشن وقع المريض. It means شنو؟ الديفكت وين؟ بالفستيبولار؟ وين الديفكت؟ بالبروبريوسبشن. هنا الفوم هدفنا we subtract this proprioception.
2 minutes.
Just finished. Thank you very much for your patience. Take home messages. The key of the diagnosis is your good history taking and good physical examination. History and examination is superior to MRI and also superior to laboratory vestibular testing in reaching the diagnosis. If your examination is negative, you should stop labyrinthine sedative for 3 days. And re-examine your patient. You need a basic tools to suppress the vision, like simple Frenzel glasses or even very cheap AMP glasses to examine nystagmus of vestibular origin. Thank you very much.
Thank you.